Hi, I'm Jeff Farnwell, Director of the MBA program at Rockford College. About 18 months ago, the Rockford Chamber of Commerce set out to make networking easier in Rockford by identifying area people you should know in business. Currently, 41 people have been recognized and celebrated as one of these people. This series of talks held at Rockford College was designed to provide a vehicle for the public to hear from and learn about each of the people you should know. I hope you enjoy this talk.
All right, well, thank you again for coming to Rockford College for our second People You Should Know talk. Today I'm excited to introduce Dr. Michael Rowe. He is a co-founder of the Rockford Spine Center, as well as a 2011 People You Should Know award recipient. The Rockford Spine Center is a place where patients with spinal conditions can go to be both evaluated and treated. Dr. Rowe takes the time to educate his patients about the different options for treatment before actually offering surgical solutions. He completed his fellowship in spinal surgery at the prestigious Washington University in St. Louis, Missouri, and he has traveled around the country giving lectures and educating other surgeons. Dr. Rowe prides himself in knowing the latest techniques to achieve the best possible surgical result for his patients. His talk today is on common myths about back surgery, and following the talk, there will be a short question and answer session. So please help me in welcoming Dr. Rowe.
Thank you. That was a lovely and pithy introduction. I want to thank the college and the chamber for this opportunity. Obviously, it's a privilege to speak to such a distinguished group. And I have to confess, this is the first time in a long time that I have lectured to a group of people that were not medical. So if I sound pretentious and like I'm talking, too much medicalese, it may be coincidental that I am pretentious, but it's accidental. It's accidental. I'm not trying to lose you. It's that I'm just out of practice. But today I did want to speak about, oh, Lauren, I need the clicker. I thought that for an audience like this, it might be good to just speak about something which I deal with quite often, which is a lot of mythology that surrounds back surgery. There's certainly a lot of fear, a lot of misunderstanding and anxiety surrounding back surgery. It's kind of a scary topic, and there's a reason for that, which I thought would be kind of interesting to talk about, just to lend some perspective. So these are my partners at the Rockford Spine Center. We're all fellowship-trained spine surgeons. We have a physiatrist from Mayo Clinic, and it's kind of a one-stop shop. That was the reason that we created it. When we first came to town, you had to go here to get your scan, you had to here to get your nerve testing, you had to get here to your x-ray, and here the doctor, and here the surgery. Though we do not do surgery on our site, we do everything else, and it's great, particularly since a lot of our patients come from pretty far away. We do all the latest and greatest stuff, this actual footage from one of my surgeries. No, we can't do this anymore mainly because insurance doesn't pay for it. So, common myths about back surgery. These are some of the most common things that I hear, not necessarily from patients, although that's because they're there to see me for back surgery. It's often at a cocktail party or a chamber event or something like where on the golf course when they say, oh, hi, what do you do? I'm reluctant to tell them, but they get it out of me. I'm a spine surgeon. They say, whoa. Whoa, and then they lay one of these things on me. Back surgery is done for back pain. That's a myth. Never let anyone touch your back. I love that one. Back surgery requires a long and painful recovery, and back surgery is only done by neurologists and neurosurgeons. It's actually a much longer list of myths that are out there, but I had to narrow it down for 20 minutes. So, first one, back surgery is done for back pain. It sounds like it should be the case. Back pain is a scourge. It is a public health issue. So many people experience it. On an annual basis. It's the second most common reason why people go to see a doctor after the common cold. And it costs billions of dollars if you think about all the costs, not just in terms of the treatment of it, but in the loss of work when people call in because they can't get out of bed. But the truth is, the vast majority of it gets better with time, no matter what you do with it. The human body is extremely adaptable. And over centuries and centuries, millennia of evolution, the body obviously is able to adapt, and the severe debilitating back pain which you hear about, it doesn't last that long. Now, there is this thing called an MRI, which can show you the inside of the spine in great clarity and detail. But the problem is that though you can see what's in the spine, it doesn't always correlate between what you see on the spine and what the patient has. And this is something that we kind of had to work out as the MRI technology became more and more available, because there was this thing called degenerative disc disease. When you look at an MRI, you see that the discs in between the bones, these discs that are like little cushions for the back, in between the bones of the spine, they show signs of wear and tear. They start to turn dark, they start to bulge or herniate, and bone spurs form. And so the medical field developed this nomenclature of degenerative disc disease. But the problem is that now we know it's not really a disease. Not really. It's just the normal aging process of the spine. Now, you can call this condition degenerative disc disease only if you are willing to call gray hair degenerative hair disease, or the dreaded degenerative skin disease known as wrinkles, often lethal. So it sounds bad, right? Degenerative, oh, I'm degenerating, I'm melting, but no, it's really not. So you take someone with this horrible, horrible looking MRI, and this guy's everything wrong. These squares are the bones. This is a slice right down the middle of the spine, low back. And the discs are these spaces between them, and you can see that this disc looks kind of normal. The ones above and below look kind of raggedy. There's a Schmorl's node here, which is just a sign of disc decay. This one has all these inflammatory changes around it. This one's very collapsed, and this bone's out of place. There's previous surgery, scar tissue all over, you name it. However, this person has no back pain. This MRI was done as more as like a dry run for an MRI scan. So just because the MRI looks bad has nothing to do with whether or not the patient has symptoms, sensations of pain or tingling or numbness or what have you. There's no correlation, or very poor correlation. By the same token, some of the people who have the most excruciating and disabling back pain have a completely normal MRI. Completely normal. They are often astounded. They think that, you know, we're going to find like a black cat in their spine or something, and yeah, it's like this is the most normal MRI I've ever seen. So it's an interesting concept that it's kind of like headache. This is the analogy I use. Your head hurts, you have a brain there, and you think, gosh, there's got to be something wrong in there. You get an MRI, and you see some dot here, some little streaky thing there. But if you operate to get rid of that little spot, does the headache go away? No, it sounds crazy. They'd put you in jail if you did surgery like that now. But there was a time when people used to do brain surgery for headaches. Back pain is a lot like that. Yes, your back hurts. Yes, there is a spine there. But if we go in and do something to that spine and make it different, does the back pain go away? Usually not. So, for years, people did all kinds of surgeries to treat back pain. Now, I'm not talking about leg pain shooting down your leg, sciatica. I'm talking about backache, right? Discectomy, laminectomy. Discectomy when you remove part of the disc. Laminectomy when you remove the bony covering to the spine. Fusion where you link up multiple levels in the spine. These are all different surgeries that were done for back pain, and the results were dismal. For generations, the results were dismal for back pain. So guess what? Word got out. Never have back surgery. Because it doesn't work. If you look at some subsegments of the population, particularly work comp, in any industrialized country in the world, work comp patients have poorer results than non-work comp patients. This classic study out of Washington State showed that total disability when surgery, a fusion surgery was done for axial back pain, meaning just in the back, nothing going down the leg. 2-year total disability, can't do anything, 64%. It's extraordinary. It's not that they didn't even get better, it's that they're like ruined, right? So, again, these people say never have back surgery. So what are the treatments for back pain? Well, one is just give it time. The vast majority of it will be bad. Yes, it's terrible when you have it. Within 24 to 48 hours, if not a week, most people are over it. Proper lifting technique, bending technique, weight loss, and regular exercises, truly preventative things being worth a pound of cure. Core strength and hamstring flexibility, yoga and inversion boots. I mean, these things can maintain a spine for a lifetime. In cases where this doesn't work, physical therapy or even pain management can get you over it, but this is not surgery. There is no knife. So with that, I'll move on to a related topic, which is my favorite: never let anyone operate on your back. So when I meet these people at a party and they say, "Oh, you will never lay a hand on me. You seem like a nice guy. You know, can I buy you a drink? By the way, you know, don't come at me with a scalpel." So people say some type of variation of this all the time. So why is that? Why do so many people come in with this notion that you must never have spine surgery? Well, let's look at history. As I said, there's a long history of people having surgeries for back pain that did not help their back pain, right? And the truth of the matter is that it's human nature. When someone has a good result from surgery, they will tell 10 people. When people have a bad result from surgery, they will tell 100. This is a maxim that we have in our field. And there is so much truth to it. Because when someone, say someone has a problem in their back, and they cannot walk, they cannot move, they have severe pain down their leg, they get better from the surgery, but not good enough to their satisfaction. They can walk now, they're not in constant pain, they just can't do the job they used to do before. So they go out on disability. And what do people say when they say, "Oh, why are you on disability?" They say, "I had back surgery." No, you are not disabled because you have back surgery. Actually, back surgery is why you are now walking. You are disabled because you injured your back, because you had a back problem that required back surgery to make it better. You are disabled for an altogether different reason, which is beyond the scope of this talk. But, and surgery on the spine is inherently scary. Even a grade school kid knows that if something bad happens to your spine, you'll be paralyzed, right? The truth is, the low back, you cannot be paralyzed. That occurs when there's an injury to the spinal cord, which is much higher in the neck and in the chest area. Once you get down to the low back, there is no spinal cord, so there is no paralysis. I've never even heard of such a thing. So then perhaps the contrapositive is, well, then why have back surgery? Well, intense and excruciating leg pain. No matter how bad someone's back pain is, when the pain starts to go down the leg, they know, oh, what I had in my back was nothing. This pain in my leg is the worst. And these people, half the time, will say, if you cannot fix this, just chop my leg off. I cannot live with this pain. They don't say, chop my back out. They say, chop my leg off. The pain is in the leg. And it is so bad. It is just brutal. Now, even in times when we can get that under control with this medicine, that injection, it is disabling or activity limiting, meaning, okay, if I just sit all day or lie down, I will survive. Pain's not that bad. As soon as I get up and as soon as I cross the room, it starts like clockwork. By the time I get maybe 50 feet out, I'm hobbling, I gotta find a place to sit. So they're not in agony, but they can't do anything that they want to do. They can't walk, they can't travel, they can't work out. I mean, stuff that's really important to people. So it becomes a quality of life issue, not a life and death issue. And where people are willing to set the bar in terms of what they can expect in terms of degradation of their quality of life is highly variable. Significant functional loss, numbness, weakness, loss of balance, coordination. If your leg or your arm is going numb and you are losing function, or like you're dragging your leg around, are you just going to live with it if someone says that, well, we can fix that with surgery? No. Most people will say, okay, I'm 40 and I can't use my leg. I think I would rather take my chances with surgery. And then you have to balance the risks versus the benefits of surgery. So when people say to me, oh, I would never let you touch me, I smile politely to the best of my ability. And I just know in my mind, they can say that because they have the luxury of never having had this kind of pain. The moment that person had this kind of pain or one of these problems, they know who to call. So but anyways, no one has back surgery because they have nothing better to do on a Wednesday afternoon. They do it because there's a reason, and because they have made that choice. And if anything, the latest and best research from a multi-center study across the country showed that whether someone has surgery or no surgery, or whether someone tries this treatment or that treatment, in the end, very interestingly, what the study showed best is that patients in the modern era are very good at making that decision and living with the consequences of that decision. So whether someone has surgery and has a good result or a bad result, or whether someone does not have surgery and chooses that and has a good result or a bad result, whatever that result may be, they're usually okay with it, indicating by analysis that they're able to make a good decision and live with the consequences. So this is why you have back surgery for leg pain, which is commonly referred to as sciatica, named after the sciatic nerve that starts in the buttock, and it's a big cable of a nerve going down the back of the leg. The thing is that people say, oh, I have a problem in my sciatic nerve. The problem is not in the nerve is in the leg. The problem is in the back. And the nerve is pinched in the back, and that nerve root contributes to the sciatic nerve. And the two most commonly involved nerves are L5 and S1, and those typically go down the back and side of the leg. Sometimes, if you pinch your L1 nerve, you'll have pain in your groin or in your flank, and so you'll be diagnosed with a hernia. If you have an L2 nerve, you'll have pain kind of in the top of the thigh. Often you'll get worked up for hip arthritis. So there are other forms of pinched nerve pain which are very much amenable to surgery or other treatments, but the key is to find the cause. So in these cases, if you unpinch the nerve, pain goes away. It's like magic. These patients are so happy. I mean, these patients enjoy like 90 to 95% satisfaction rates at 2-year follow-up, which is about as good as it gets in medicine. So this is why you have back surgery, and this is why I'd like to say our patients are very happy, because we kind of made a philosophical choice when we started the Spine Center, was to really stick to quality, only do surgeries for this problem. If you look across the country, I must tell you that the majority of spine surgeons who do back surgery do it for back pain. And they probably live in a much bigger house than I do. But their waiting room is often a very miserable place, because there are a lot of people there who are no better or worse. So, back surgery requires a long and painful recovery. This is another thing. I mean, there was a time, not so long ago, that if you had a spinal fusion, you would be in a body cast for 18 months. Not a brace, plaster cast. 18 months. I mean, it's messy, it's smelly, and it's heavy, and it's, yeah, I mean, it's no fun. So, furthermore, the way that surgery was done back then, these incisions were humongous. I mean, like, huge incisions. For what? I don't even know why they did them like that, because they just didn't know any better. And they would just take the spine apart. This is a cross-section of the spine, as if someone's face down and we're looking from their head down the spine. So this is the vertebral body, here are the nerve roots. These are the muscles that form the back muscles, back here. Interestingly, for those beef lovers here, this psoas muscle is the filet mignon, and this is the sirloin. So so on a cow, these are a little different, but if a T-bone, for instance, is a slice right through here, from this part of the vertebral body up through there, and that's the vertical part of the T. So sirloin and porterhouse, yummy. But I digress. So anyways, when you do the old-fashioned surgeries, you take this apart, peel the muscle off bone, a lot of scar tissue is a disaster. Now, we do so much minimally invasive surgery. My average minimally invasive surgery has an incision about 1/2 inch long. That's smaller than your fingernail, smaller than your pinky nail. So it's a tiny surgery, fast recovery, much less pain. These are outpatient surgeries, tiny incisions, and the medically complex, such as the elderly in some cases, they tolerate this much better. Not everybody does it. It is technically demanding to do a surgery that used to have this much room through this much room. And your personality has to be compatible with it. Not everyone is eligible for it, but if you're a candidate, I see no reason why you shouldn't have it. I get this a lot. Laser. Do I do the surgery with laser? Somehow people think if you use a laser, then you don't make an incision. That couldn't be further from the truth. A laser, it's just a way of burning tissue, and it's been around forever. And though it's a great technology, we haven't figured out a way to use it. There are very few fields that are able to use it, and we would all love to use it. Because we would all love to be able to tell patients, yes, I use a laser, and I'm awesome at it. But we don't. So it's a great technology, still searching for an application, and actually there's this place in Tampa called the Laser Spine Institute. There was an expose run in Bloomberg on it, if you want to follow this link. Ew, can I say this? Yes, I think I can. It's a scam. It's a scam. It's a cash-only practice. and they make an enormous amount of money, a lot of overseas marketing, a lot of people who are just scared of, you know, regular back surgery, so they have this. But there's nothing to it, and the vast majority of patients who supposedly have a good result, if you check back with them in a few months to a year, they're back to the way they were, just poorer. And the people who did get better, they would have gotten better with a regular surgery. So, buyer beware, caveat emptor. So, this is what we treat. This is a lumbar disc herniation. This is when a disc, this is in cross-section, we're looking again down the spine, it ruptures, and this stuff from the inside comes out and puts pressure on a nerve that exits the spine and causes a lot of pain. So, the way that we're able to do these surgeries using tiny incisions is, instead of making a big incision and peeling the muscle off bone and getting down there to the spine, which is, it's pretty far down there in some cases. Instead, I use these tubular dilators so that through this cylindrical tube, I get down to the exact spot where I need to be, and I can remove the offending material and close up. Tiny little incision. So here's a little animation that shows how the surgery is done. So someone's got severe pain in their calf, but the problem is not in the calf, the problem is in the back. And this is called a referred pain. If you are feeling nauseated, it will pass. So there. It's a pinched nerve at L5 from a herniated disc deep inside this patient's body, under many layers of muscle, fascia, skin. So using basically X-ray videography, we're able to locate the spot that the nerve is pinched. And if you're going to use a tiny little incision like that, you got to really be precise. There's not much room for error. But once you're in the right spot, using various landmarks and the help of this X-ray, we're able to locate the incision, the ideal spot, and then using these tools, we spread the muscle fibers apart. You see, the muscle fibers run in this linear parallel fashion. But by passing these dilators of a greater and greater diameter through, it kind of spreads the muscle fibers apart. You don't cut them, because then when you cut them, they don't heal real well. You just spread them apart, so when you pull that thing out, the fibers come together, there's no scar tissue, it's like you were never there. So once you get this tube into the right spot, you put in a light source. I personally use a microscope, so I have 20, 30 times magnification, and this is all you need to see. So through this little tube, using specialized instruments that allow me to keep my fingers out of the way, we remove a little bit of muscle, a little bit of bone here. This ligament here covers the spinal nerve roots themselves. And I mean, yeah, this is how you do it. So we get in there, now you guys can all go out there and do it. See one, do one. So we peel back this ligament, and voila, we have this hot, red, inflamed nerve root that is being pinched by the disc pushing up from underneath. So we move the nerve root aside, we cauterize the little vein that usually accompanies it, just like that. And then we cut out the piece of disc that's pushing on the nerve. And again, you can do this through a big incision. I prefer to do it through a small incision. In the end, the results are about the same. It's just that the recovery is so much faster with this, and there's less collateral damage. So once the nerve is unpinched, job is done. You just pull this tube right out of the back. All the muscle fibers collapse back into where you were. Half-inch incision to show for it. It's a good surgery. Far, far advanced compared to the way it was done even 15 years ago. So about a third of my patient surgeries are like this. Lumbar discectomy, full recovery for these patients in 7 days, after which they have no restrictions. No restrictions at all. We teach them preventative techniques so that they do not re-injure. 7 days is not, oh, back surgery takes a long time to recover. Cervical foraminotomy, same thing, 7 days. So I do a lot of neck surgery. These neck fusions in particular, these patients have no pain. They have a bit of a sore throat, but no pain. And now, about a third of my volume is outpatient. That's a lot. Some surgeries cannot be done like this. Like if you have some horrible scoliosis and you're all twisted up like this, you need a big whack. And we do those too. But these are nice when this is all you need. So last thing I would touch on is this myth. Back surgery is only done by neurologists or neurosurgeons. This, I'm not exactly sure where it came from. I think it's more of a regional thing. In some parts of the country, Orthopedic doctors do the spine surgery in some parts of the country. Neurosurgeons do the back surgery. But basically, just to clarify for those of you in the audience, a neurologist is a doctor. They do a neurology residency, and they treat stroke, Parkinson's, neuropathy, multiple sclerosis, things like that that pertain to the brain, spinal cord, and sometimes to the nerves. But they are not surgeons. They are not surgeons. Neurosurgeons are very much surgeons, and they treat the brain, so aneurysms, brain tumors, as well as the spine. Orthopedic surgeons, like myself, we treat joint problems, you know, hips, knees, shoulders, fractured bones, and the spine. But an orthopedic spine surgeon, like myself, I treat the spine, and the spine. So this is all I do. This is all I do. And the reason that I can call myself an orthopedic spine surgeon is that I did this fellowship. Not everybody knows what this is. Basically, after you complete a residency in either orthopedic surgery or neurosurgery, so that's like 6 years doing, you know, learning about all that stuff, whether it's brain and spine or joints and spine. When you are done, if you want to learn how to do the really complicated stuff, you do an additional year, because, you know, 17 years of education and training is not enough sometimes. You have to do one more to really get it right. So then we do this extra year, and usually, if you're lucky, like I and my partners, we go and we learn from the masters in the field. Like anything, there are good fellowships and bad fellowships. But in the modern era, it's more important that your surgeon be fellowship trained, because this added layer of training usually means that you're there, you're at the top of your field. But of course, training is not everything. Ethics is a huge part of picking a surgeon. I cannot stress this enough. As you can imagine, in the field of back surgery, if you just want to get out there and make a buck, you can do it, but I would not say that is ethical, although unfortunately, just like anything, there are good doctors and bad doctors. Bedside manner, I mean, this is not, what we do in spine surgery is not life and death. Like if someone has cancer, and you take out their cancer and you save their life, you probably don't need much of a bedside manner, although surely it is a plus. You just save that person's life. They probably don't care whether you're a nice guy or not. They're just happy to be alive. End of story. Spine surgery, we treat pain. We treat quality of life issues. These are things that you can only get to know if you talk to that patient, talk to their family, really kind of get a sense of like, how much is this affecting them? That takes time. Not a lot of surgeons. Surgeons are not really known for wanting the best at taking time and talking to people, just spitballing. So yeah, that's important. And then of course reputation and track record, and that is something that obviously you got to earn. That's something that, you know, each day you got to get in there, do your best, help some people, and that's where I'm very, very, perhaps most proud of the Rockford Spine Center, because you know, whatever the case may be, our reputation, our track record online, especially the wealth of positive commentary and ratings in this community and beyond is really, it's humbling, but it is also very much an endorsement. So if someone's brand new to town and you don't really know much about them, they may be good, they may not. I would say that not everyone in our field is what I would consider excellent, but check out their reputation before you proceed. So in summary, many myths do surround the notion of back surgery. History has taught us what we can and cannot fix, and there have been tremendous advances in surgical technique and understanding, even lately, which have improved our ability to help patients, and really that's what it's all about. And with that, I thank you. Only one of these people in this picture is a professional model, and she's sitting right back there. All right, so I'd be happy to take any questions.